Welcome back, class. We'll now begin a discussion on other disorders, including dissociative personality and eating disorders, a sample of the few of the many other psychological disorders. We'll look at dissociative disorders, separation of consciousness, dissociative identity disorder, personality disorders, with a focus on antisocial personality disorder, and then eating disorders. So let's look at dissociative disorders. Dissociation is a separation of conscious awareness from thoughts, memory, bodily sensations, feelings, or even from identity. So a separation from your conscious awareness. And recall what we mean by conscious awareness. Conscious awareness is that you are aware of yourself and your environment at any given time. So here with disassociation, we're seeing a separation of that from your conscious awareness, from your thoughts, your memory, and so on. Dissociative disorder is a dysfunction and distress caused by chronic and severe disassociation. Examples are dissociative fugue state. Fugue means running away. Wandering away from one's life, memory, and identity with no memory of them. So this would be the individual who finds themselves in another city, maybe hundreds of miles or thousands of miles away from where their home was established, and they not only have run away, but they have no memory of their personal identity or the life that they had before they relocated to this particular area. And then we have the dissociative identity disorder, the development of separate personalities. This is what they used to call multiple personalities. It is somewhat of a controversial type of diagnosis, as we'll see as we discuss this. So let's look at dissociative identity disorder, formerly known as multiple personality disorder. In the rare actual cases of DID, the personalities are distinct and not present in consciousness at the same time, may or may not appear to be aware of each other. Now, you've seen movies, or at least seen television shows that really will display cases fictionalized for the movie of DID, or multiple personality disorder. So you have someone who will, for example, commit a crime, and then they're caught, and you realize that I didn't kill this person, but maybe one of your multiple personalities did. And that, of course, leads to a whole drama, and that's why the movie can be somewhat more entertaining as people tease through that and try to figure out what's going on. But those are some of the issues that can pop up when we have this idea that a person can establish more than one personality in the same body, and one personality may do things the other personality, or the main personality, or the one that was born into that, may not be aware of, and that can cause some issues. Now, normally we see this is associated, if you look at TV and movies, with some sort of traumatic event when they were a kid, something that they could not deal with, and the original personality sort of develops an alternate personality that has the capability of dealing with whatever traumatic event that is. Again, this is somewhat of a controversial thing because it's hard to sort of suggest that there's some proof that there are indeed personalities that are different from the one that is the primary one for that particular body. There are alternative explanations for DID. Dissociative identities might just be an extreme form of playing a role. And we talked about this previously in the semester, the power of playing a role. People can literally get lost in a role they're playing. And so this is thought of potentially as being an extreme case of that. The dissociative identities might just be an extreme form of playing a role. DID in North America might be a recent cultural construction similar to that idea of being possessed by evil spirits. Cases of DID might be created or worsened by therapists encouraging people to think of different parts of themselves. Now, looking at the evidence whether or not DID is a real thing or not, different personalities have involved different brainwave patterns. So we have seen that if someone is a different personality now, they seem to have a different set of brainwave patterns. Different left-right handedness. So someone who is born righty, they switch to another personality, they seem to be now able to use their left hand as their dominant hand. Different visual acuity and eye muscle balance patterns. Patients with DID also show heightened activity in areas of the brain associated with managing and inhibiting traumatic memories. So there's some evidence there. So explaining fragmentation of personality from different perspectives, we have the psychoanalytic perspective, diverting the id, cognitive perspective, coping with abuse, learning perspective. Disassociation pays. For example, you get reinforced for it. So if you're able, the primary host personality is able to escape the traumatic event, then that reinforces that type of behavior. So they're more likely to do it in the future. And we have social influence. The therapist may encourage this to be occurring. Okay, now DID, I'm sure you'll be able to find some movies that sort of demonstrate this type of thing. One that comes to mind is a movie called Identity. Another that comes to mind is Primal Fear. A little bit more of an adult movie though, in that it does have some very graphic scenes. But again, these types of movies do demonstrate, some of the issues that result if DID or multiple personality is actually a real thing, and when they get into the court system or the legal system, it can cause quite a bit of consternation in trying to figure out what to do with an individual. Now, some other disorders. Let's look at eating disorders. Anorexia nervosa, bulimia nervosa, and binge eating disorder. These may involve unrealistic body image and extreme body ideal, the idea of what your body you want your body to be, a desire to control food and the body when one situations can't be controlled. You can control what you put in your mouth because you can't control anything else going on in your life. Cycles of depression. Sometimes we will eat in order to feel less depressed. We've talked about this previously too, that eating certain types of comfort foods will raise your serotonin levels, which then makes you feel less depressed. Health problems, and so on. So let's look at some of these. Anorexia nervosa is a compulsion to lose weight coupled with certainty about being fat despite being 15% or more underweight. This person would look into a mirror and always see somebody who is overweight, even though anyone objectively would basically state that no, you're skinny if anything. So anorexia nervosa, they have this compulsion to lose weight, and they have this certainty that they're fat, overweight already. 0.6% meet the criteria at some time during their life. We usually will see this with adolescent, particularly adolescent females, but we do see males have this particular issue as well. For example, if they're in certain sports, an adolescent male, let's say in high school, may develop this particular type of situation. For example, if they are on the wrestling team, which has a great deal of concern about weight, that might be the case for a male. We have bulimia nervosa, compulsion to binge. That means eat a lot, so eating large amounts fast, and then purge by losing the food through vomiting, laxatives, or extreme exercise. Obviously, if someone is suffering from anorexia nervosa, they're more likely to be observed as having that condition. With bulimia nervosa, however, it may be a little bit more difficult to, because normally they don't seem to be having this great deal of underweight. They look normal to slightly above average weight. But the idea they are suffering from an eating disorder. The prevalence of that is around 1%. Then we have binge eating disorder, which is a compulsion to binge followed by guilt and depression. And that's approximately 2.8% prevalence. So eating disorders associated with family factors. All right. Having a mother focused on her weight and on child's appearance and weight seems to be a particular factor for developing this disorder. Negative self-evaluation in the family. They're talking to you all the time about your weight or apparent overweight or what have you. For bulimia, if childhood obesity runs in the family. For anorexia, if families are competitive, high achieving, and protective. Cultural factors. Unrealistic ideals of body appearance, which can be seen in magazine, television, and movie ads about how, for example, the female body, the ideal is to appear, and so on. Now let's look at personality disorders. Personality disorders are enduring patterns of social and other behavior that impairs social functioning. There are three clusters or categories of personality disorders. We have anxious or anxious versus avoidant personality disorder, ruled by fear of social rejection. Eccentric or odd, schizoid personality disorder with flat affect and no social attachments. And dramatic, a histrionic, attention-seeking, narcissistic, self-centered, or antisocial / immoral perspective of personality disorders. Anxious, eccentric, odd, or dramatic. So antisocial personality disorder, persistently acting without conscience, without a sense of guilt or harm done to others, strangers, and family alike. The diagnostic criteria include a pattern of violating the rights of others since age 15, including three of these: deceitfulness, disregard for safety of self or others, aggressiveness, failure to conform to social norms, lack of remorse, impulsivity and failure to plan ahead, irritability, irresponsibility regarding jobs, family, and money. Which kids may develop antisocial personality disorder as adults? About half of children with persistent antisocial behavior develop lifelong APD. Which kids are at risk? Psychological factors. We have those who in preschool were impulsive, uninhibited, unconcerned with social rewards, and low in anxiety. Those who endured child abuse and or inconsistent, unavailable caretaking. Biological APD risk factors. Antisocial or unemotional biological relatives increased risk. Some associated genes have been identified. Lower levels of stress hormones and low physiological arousal in stressful situations. Fear conditioning is impaired. Reduced prefrontal cortex tissue leads to impulsivity. Substance dependence is more likely. So oftentimes people tend to try to equate antisocial personality disorders with criminality, meaning they are criminals. This is not necessarily the case. So here we see this diagram where we have the overlap between criminals, people who repeatedly commit crimes, and then people with antisocial personality disorder. There is indeed overlap, but not a great deal. Many career criminals do show empathy and selflessness with family and friends. Now that's a key point. Criminals can be very cruel and vicious individuals, but not so with people who are their family and friends. They may have empathy. They may have selflessness there. When it comes to antisocial personality disorder, they're not affected in the same way. They don't care necessarily about family and friends in the way that we would think of it. Many people with APD do not commit crimes. So antisocial crime, associated factors. Though antisocial personality disorder is not a full picture of most criminal activity, what can we say about people who commit crime, especially violent crime? Well, here, lower levels of physiological arousal, as measured as levels of the adrenaline levels, under stress may enable taking violent action without feeling anxiety or panic because they have this low physiological arousal when they're under stress. They can commit acts and actions without feeling anxiety or panic. So something to us, something happened, we're doing something we shouldn't be doing, somebody pops up and we're particularly in danger, we may feel the arousal and the stress has a great deal of impact on us. But with the person that has APD, not the case. They don't feel the anxiety. They don't feel that panic. So in this graph, we see males with criminal convictions as adults had lower levels of arousal as 13-year-olds. So they measured their levels of arousal, and now we see the following. No criminal conviction versus criminal conviction. So with males at the level here, we see at 13-year-olds, they are able to say that they have higher levels of this adrenaline, and we can see here that in non-social situations it's much less, and they're more likely to have criminal conviction. Biosocial roots of crime, the brain. People who commit murder seem to have less tissue and activity in the part of the brain that suppresses impulses. So we look at the normal brain where we see a lot of activity, and then the murderer on the right, we see a lot less activity demonstrated by the yellow and red there. Other differences include less amygdala response when viewing violence. Okay, so remember, the amygdala is where we have this emotional response to things. And so they can see some sort of violent actions and activity, but their amygdala just doesn't kick in as someone who doesn't suffer from this particular disorder would. An overactive dopamine reward seeking system. For example, they want to get some sort of reward for something, and they're seeking to it because their dopamine reward system is much more powerful than ours. How common are psychological disorders? Countries vary greatly in the percentage of people reporting mental health issues in the past year. Prior year prevalence of disorders in selected areas we see here from the World Health Organization. Any mental disorder, we see that we are greatly ahead of many. As well as with serious mental disorders, we tend to lead the pack a little bit as well. Let's look at the rates of psychological disorders. So the list takes a closer look at the past year's prevalence of various mental health diagnoses in the U.S. Generalized anxiety about 3%, social phobia around 7%, phobia of specific objects around 9%, mood disorder 9.5%, OCD 1%, schizophrenia 1.1%, post-traumatic stress disorder 3.5%, 4.1% for ADHD, and 26.2% for any mental disorder. We do see there are vulnerable factors in ages for developing mental disorders. Who is vulnerable to mental disorders? Well, poverty increases the risk of many mental disorders, including aggression and anxiety. The immigrant paradox: despite the stress of immigrating, those who immigrate to the USA have a lower risk of disorders than those actually born in the U.S. Age vulnerability. Many disorders begin to show symptoms by early adulthood, developing on average around 20 for OCD, schizophrenia, bipolar, and alcohol dependence. Showing some signs earlier are phobias around the age of 10, and antisocial personality disorders, some symptoms by age of 8. And developing later than 20, major depressive disorders. Outcomes for people with psychological disorders. There are risks to be watchful of, obstacles to be overcome, and improvements to be made, often with the help of treatment. Some people with psychological disorders do not recover. Some achieve greatness even with a psychological disorder. In the next unit, we will begin our discussion of applied psychology areas, and we'll start off by looking at therapy.